بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Today we will study the malignancy of hematopoietic and lymphoid tissue, which are called leukemia or lymphoma. The cancer of hematopoietic or lymphoid cells may be called leukemia or lymphoma according to the clinical presentation. If the presentation in the form of bone marrow infiltration and peripheral blood infiltration, then the cancer is called leukemia. While if the presentation is in the form of lymphoid organ swelling, in the form of lymphadenopathy or hepatosplenomegaly, this cancer is called lymphoma. Today we will be concerned with the study of leukemia, which is the cancer of blood or bone marrow cells, leading to infiltration of the bone marrow by malignant cells, which may or may not disseminate to the peripheral blood. According to the onset, the leukemia is classified into acute and chronic according to the onset of presentation. While according to the origin of malignant cells, it is classified into lymphoid and myeloid leukemia. Then we have four types of leukemia: acute leukemia in the form of acute lymphoblastic leukemia and acute myeloid leukemia, chronic leukemia in the form of chronic lymphocytic leukemia and chronic myeloid leukemia. By the definition or by the name, the acute leukemia means rapid onset of increase of number of immature blood cells in the bone marrow, which may or may not infiltrate the peripheral blood. The infiltration of the bone marrow by immature blood cells and rapid increase of the number of immature blood cells in the bone marrow will inhibit the normal hematopoiesis and replace the normal hematopoietic cells, resulting in a peripheral blood cytopenia. Then the blood cells or immature blood cells will infiltrate the peripheral blood and appear in the blood film. The acute leukemia is diagnosed by the presence of blood cells in the bone marrow or peripheral blood in the percent of 20% or more. We will study the laboratory finding in the case of acute leukemia and how to diagnose a case of acute leukemia. First, we do what is called CBC or complete blood count, where we will find the white blood cells may be increased, normal, or decreased. The blood cells will infiltrate the bone marrow and may or may not infiltrate the peripheral blood. If the blood cells infiltrate the bone marrow and don't disseminate into the peripheral blood, they will inhibit the normal hematopoiesis, the normal granulopoiesis, and will induce leukopenia in the peripheral blood. Then acute leukemia may or may not presented by leukocytosis. The blood cells infiltration of the bone marrow will inhibit the normal hematopoiesis, and thus the patient will be presented by anemia and thrombocytopenia. Anemia and thrombocytopenia are early presentation in the case of acute leukemia. If we examine the blood film or bone marrow smears, we will find a blood count in bone marrow or blood film in the percent of 20% or more. Then we diagnose. When we find this percent of blood cells in the blood film or bone marrow, we can diagnose a case of acute leukemia. We need to further classify the origin of the acute leukemia. It is either myeloid or lymphoid acute leukemia. We can do that by cytochemistry, immunophenotyping, and cytogenetic. Cytochemistry means examination of the content of the cells by adding special kits to the blood film and observe the results of the test. We have some cytochemistry tests as MPO or myeloperoxidase, Sudan black B, and TDT or terminal deoxynucleotide transferase. Then we can diagnose the origin of the acute leukemia by the presence of certain markers on the cells, whether on the surface of the cells or inside the cells or inside the nucleus. We use monoclonal antibodies labeled by a fluorescent dye in a test known as immunophenotyping or flow cytometry or immunohistochemistry. The cytogenetic may aid in the diagnosis and may aid in the classification of acute leukemia, as some types of acute leukemia may be associated with some cytogenetic abnormalities. If we start the studying of acute myeloid leukemia, we can define the acute myeloid leukemia by a rapid increase in the number of immature myeloid cells in the bone marrow and or bloodstream. The acute myeloid leukemia is also diagnosed by the presence of blast cells in the bone marrow and or blood film in the percent of 20% or more. The laboratory diagnosis of acute myeloid leukemia include the complete blood count, in which we will find leukocytosis, normal leukocytic count, or leukopenia, and mostly we will find anemia and thrombocytopenia. The blood film and or bone marrow smear will show a blast percent 20% or more. The cytochemistry in acute myeloid leukemia will give a positive T2, myeloperoxidase, and Sudan black B. Immunophenotyping will find the myeloid markers on the myeloid blast in the form of positive myeloperoxidase CD13 and CD33. The cytogenetic aid in the classification of acute myeloid leukemia and may share in the decision of treatment of a case of acute myeloid leukemia. Acute myeloid leukemia is morphologically classified into these 8 subtypes according to the malignant cell found in the blood film and or bone marrow. It is classified into these 8 subtypes: M0, M1, M2, M3, M4, M5, M6, and M7 according to the type of malignant cells or type of myeloid malignant cells. M0 will include acute myeloblastic leukemia minimally differentiated, which include blasts not differentiated and can be differentiated by morphology. It is only differentiated by immunophenotyping. M1 means acute myeloblastic leukemia without maturation, which include 90% or more plus cells. M2 acute myeloid leukemia with maturation, which include some mature cells. M3 is acute pro-myelocytic leukemia, where the malignant cells are not blasts and the malignant cells are pro-myelocytes. M4 acute myelomonocytic leukemia, where the malignant cells are myeloblast and it include also a monocytic component. M5 acute monoblastic leukemia or acute monocytic leukemia, which include monocytic cells at a percent of 80% or more. The blast may predominate and called acute monoblastic leukemia, or may be few and called acute monocytic leukemia. M6 acute erythroid leukemia, where the malignant cells are erythroid, are myeloid blast and erythroid cells. M7 acute megakaryoblast leukemia, where the malignant cells are megakaryoblast. The following will be the acute lymphoblastic leukemia, which means a rapid increase of the number of immature lymphoblastic cells in the bone marrow and or peripheral blood. It is also diagnosed by presence of lymphoblasts in the bone marrow or peripheral blood in the percent of 20% or more. These are the laboratory findings in the case of acute lymphoblastic leukemia. The complete blood count may show leukocytosis, normal leukocytic count, or leukopenia, and mostly there will be anemia and thrombocytopenia due to the acute onset of the disease. The blood film and or bone marrow will show blast cells in the percent of 20% or more. Cytochemistry will give a positive TDT or terminal deoxynucleotide transferase, and will give negative MPO or myeloperoxidase and sodium black B. Immunophenotyping will show the lymphoid markers on top of plus, as in case of B lymphoblastic cell will express CD19, and the T lymphoblastic cell will express CD3. Cytogenetic may aid in the classification and may share in the decision of treatment. According to the morphology, the acute lymphoblastic cell is classified into these three morphological subtypes: L1, L2, L3. The L1 will include small uniform plus cells. L2 will include large varied cells, and L3 will include large uniform cells with vacuoles. Then we will shift to the chronic leukemia. The chronic leukemia means a chronic progressive increase of the number of blood cells. Relatively mature white blood cells will increase in number, and there must be infiltration of the peripheral blood in most of the types of chronic leukemia. The chronic leukemia typically take months or years to progress. And as a laboratory finding in the chronic myeloid leukemia, it is mostly presented by a leukocytosis. Anemia and thrombocytopenia are not a common presentation in the chronic leukemia, and if present, there will be late and will be mild. According to the origin of malignant cells, chronic leukemia will be classified into chronic myeloid leukemia and chronic lymphocytic leukemia. In the chronic myeloid leukemia, the complete blood count will show leukocytosis and shift to left, and will be presented with eosinophilia and basophilia. The blood film will show eosinophilia and basophilia and shift to left. The chronic myeloid leukemia must be differentiated from the myeloid leukemoid reaction. The myeloid leukemoid reaction, in the myeloid leukemoid reaction, there is a leukocytosis, shift to left, and the cells in the blood film will show toxic granulation and vacuolation, while in the chronic myeloid leukemia there will no toxic granulation or vacuolation. The lab score or leukocyte alkaline phosphatase score will increase in the myeloid leukemoid reaction, while it decrease or be absent in the chronic myeloid leukemia. The actual diagnosis of chronic myeloid leukemia is the cytogenetic study and the presence of Philadelphia chromosome, which involve the translocation between the chromosome 9 and the chromosome 22, and fusion of the BCR gene with the APL gene to produce the BCR-APL fusion gene. The Philadelphia chromosome will be the chromosome 22. In the chronic lymphocytic leukemia, the complete blood count will show persistent lymphocytosis more equal to or more 5,000 per cubic millimeter. The blood film will show infiltration by mature lymphocytes, and anemia and thrombocytopenia are uncommon and late. If present, they will be mild. The actual diagnosis of chronic lymphocytic leukemia is the immunophenotyping, which detect the immunophenotyping finding specialized for chronic lymphocytic leukemia.